No problem. We'll get started anyway.
Sorry.
Welcome, everyone. Welcome to another Tumor Talk. As everyone knows, this is a collaborative effort in the Journal of Neuro-Oncology, highlight recent publications in the Journal of Neuro-Oncology, talking about to the field of brain and spinal cord. And the editor-in-chief of the Journal of Neuro-Oncology. And today we have Nitesh Patel from Rutgers University, one of the chief residents. And we're pleased to invite Caroline Apra and Paul Roblot from France, actually, discussing their recent paper, discussing female gender and exogenous hormone intake as risk factors for spheno-orbital meningiomas. So welcome. We love going international, and we love when we get guests from overseas. So thank you so much for being a part of this.
Thank you. Do you want me to get started with the presentation?
So,
please do.
Yes, please. I'm having a little bit, but yeah, go ahead.
Okay, I'm sorry, I cannot hear everything you're saying. So if you cannot hear me, please tell me. Maybe my connection is not so good.
No, I can hear you fine. I think the connection on Randy's end may be a little bit temperamental. But please go ahead and summarize or go through the presentation. We appreciate you being here, and then we'll talk a little bit about the article.
Okay, thank you very much. It's a great honor for us to present our work here. We're really happy to talk about this article which has been published really recently in the Journal of Neuro-Oncology in June. The title is Female Gender and Exogenous Hormone as Risk Factors for Spheno-orbital meningiomas. We've been working on it in different hospitals in Paris, and it's been mainly done in the Rothschild Foundation in Paris. I'll present it in about 10-15 minutes, and if you have any question, I hope you will ask them at the end. So,
thank you.
Can you hear me?
Yes.
Yes.
We can hear you.
Can you see my next slide or not? It's all...
No, it seems to be lagging. I just see the title.
Okay.
Randy, can you advance the slides?
No, I only see the title screen as well right now.
Okay. I'm really sorry about that. Okay. Okay, there it goes. Everything.
There you go.
There. So, hormones and meningiomas, it's a very fashionable topic at the moment. It's been a very fashionable, especially in France, for a few years. In 2018, there have been French national guidelines issued by the National Health Agency for the use of cyproterone acetate in the general population. And they're issued guidelines about screening for meningiomas in basically all patients who received cyproterone acetate for any reason. And this had a consequence that most people, they stop their hormonal treatments. So there is really big talks about it in France. And we have to be very careful when we discuss hormones and meningiomas, because hormones are very common treatments and meningiomas are really rare. And I really don't want people to think we have to stop taking hormonal treatments because of a really low risk of meningiomas. I stopped telling that at the beginning because the rest of the presentation will be the link between the two of them. So I want to make it clear that it's a really serious topic, and we do not use hormones, but we know about meningiomas, but we have to respect the other indications. So at the beginning, when we started this work, we were not interested in hormones at all. We were just interested in what I will call SOM, which are spheno-orbital osteomeningiomas. They are quite rare tumors, but as neurosurgeons, we come along them very often in the outpatients. There are bony and meningeal tumors that arise in the sphenoid and the orbit. So if you On the picture D, you can see this bone on the side of the orbit on the right eyes, which is really abnormal, it's irregular, and there is proptosis on this side. Sometimes this tumor can cause visual loss, sometimes epilepsy, headaches, and then there is indication for operating the patients. Quite unusual for neurosurgery. The surgical management is well described and it's quite consensual. There has been a nice review about it in 2018, but the fact is there are still 29% of recurrence of tumors, ranging from 10 to 56% in this review, after a mean time of 54 months, which means one-third of the patients need to be reoperated because the meningioma and the osteoma come back. So this treatment, this surgical treatment, is optimal because everybody agrees about the technique, but it's definitely not perfect and there are still many questions about it. That's why we went through the series of patients with these tumors we had in the Rothschild Foundation. And when you look at it, have you noticed that all the patients really look alike? In our practice, between 2005 and 2019, that they were all in their mid-50s, and there were 90% grade 1 meningiomas. And most of them had progesterone receptors on histological testing, which is it's 96% in females, which is really high compared to the 70% rate in grade 1 meningiomas in general. When you see the curve in the figure A on the right side, you can see this peak of patient around 50, which is really shows one zone, one age, which is really high risk for this type of meningioma. In the literature, we performed a systematic review. I will not go through the whole guideline and the whole screening we did, but we found all the literature series describing spheno-orbital meningiomas, and we found that by the patients were women. We compared it with the range of women in meningiomas in general. We know more women than men have meningiomas. This is not a surprise, but usually it's about 75%. In spheno-orbital meningiomas, it's more about 86 to 90%, which is significantly higher. So if we go through our series, we were wondering if there are other characteristics that are particular to this population and this pathology. So we could get a lot of really precise information because we called back all the patients from our series to ask them everything about their medical history and gynecological history. So globally, they had no special disease, no gynecological history. There was absolutely no cranial radiation, no neurofibromatosis. So that's the most common risk factors for meningiomas. Their BMI was a bit higher than the general population compared to this group, but nothing special about it. And the gynecological status, we really were interested in it because the mean age of the population is around 50, and that's basically when women start to be postmenopausal. But we guess that spheno-orbital meningiomas are slow-growing tumors, so they probably have developed for many, many years before they come to our clinic and before they get operated. So these figures of about half the patient being premenopausal and half the patient being postmenopausal are not very relevant because they just reflect the time of surgery. So we try to get more information about hormone intake. That's a really difficult thing to obtain when you talk to the patients. We'll go through it after that. But basically, 78% of the patient had taken some hormonal treatment at some point. Most of them had taken progesterone analogs. And if you go through the treatments, many of those molecules have already been incriminated in developing meningiomas. In particular, cyproterone acetate, the first one in the table on the right, and normegestrol acetate. And also cloramidinone has already been described. So it's quite logical that we find the 3 drugs as the most frequent hormonal treatment in these patients. As you see, it's not very precise because in some patients it's very difficult to get the information, but only 20% of patients had not received any exogenous hormonal intake in their lives. I just want to precise that we were talking about, of course, the time before surgery, and that all the patients were asked to stop their hormonal treatment when they came to the clinics, but they were operated. So we didn't know about what happened when they stopped the treatment. We'll go through it after in the next slides. Just to go into the detail, 8% of the patients had multiple meningiomas, which is really low compared to the literature concerning spheno-orbital meningiomas, because in some series, up to 30% of patients have other meningiomas or bilateral spheno-orbital meningiomas. But in our series, all of the patients with multiple meningiomas were women and had received hormones at some point. All patients who received extra-progesterogenic pills had received all generation progesterone. So that's high dose and molecules that have been incriminated in the risk of meningioma. In the subgroup of patients who needed recurrent surgery, there were 26 patients, 25 were women, and 75% of them had received exogenous hormonal treatment. There was one man in this group. We could not call him back because he wouldn't answer, but we found in his file that he had erectile dysfunction. So he might have some hormonal problem, but this is really not sure. It's just because we wanted to have as many information as possible, but of course, nothing is proved about it. So just to summarize all that, we found that the vast majority of patients are women and they received exogenous hormonal intake in their lifetime before they developed spheno-orbital meningioma, which needed surgery. Of course, this is really limited because it's a retrospective study. So it's really hard to get the precise molecules. Most women you talk to, they consider hormonal treatments are not treatments. It's just like part of their daily life. So they would not remember that. Also, we only focused on operated cases because we could not get the others, which is a real problem because what we would love to have is all the cases, get the patients who stopped their treatment and measure if the osteomopath regressed, if the proptosis reduced, and if surgery was really needed, because that would be a really nice information to get. And the other thing which is really difficult to get, although it should be possible, but it's really hard, is to get the rate of hormonal treatment in the general population for women who are the same age, same generation, because it's very different for women who are 60 now and women who are 20. Habits are very different. We cannot just extrapolate the rate of, for instance, female who take the pill nowadays. You cannot say 20 years ago the rate was the same. This is not true. So that's something we're discussing with gynecologists, but it's really hard to get this information reliably. It's also difficult in general to compare the series in the literature or to molecular analysis because in spheno-orbital meningiomas, complete resection is not possible. So most of the time there will be a part of the osteoma or a part of pathological meninges still there. And when there is a recurrence, it's really hard to know how much the surgeon has taken out. Of course, you have the postoperative MRI that can help you, but it's very difficult to compare because of the different surgeons' habits. Well, that's always the problem in surgery, so it's just a minor problem. Also, spheno-orbital meningioma in the literature is quite a vague entity. There are some papers describing and classifying those meningiomas, but when you talk to different clinicians, some of them will include intraorbital meningiomas, some of them will include only those with a bony part, and others will also include sphenoid meningiomas without problem in the orbit. So it's a very heterogeneous group. And also when you have only a bone, it's very difficult to get molecular analysis on that. So I'll just come to it in the next slide. But if we want to know more about the genetics of this, it's something we have to keep in mind. So just 2 points for discussion. Is hormonal treatment interruption enough? So we went through the literature. Our senior resident, Paul, did it very thoroughly. And so we went through all the meningiomas in the literature, which regressed. So we did a very thorough Prisma review, and we found that in the literature, there are only 24 patients who were reported with regress. In this group, some of them are on the skull base, that's the majority of them, and some of them the convexity. You will probably agree that this separating between skull base and convexity is quite vague, but we know what it means. And in this group, there is no spheno-orbital meningiomas in all 24 patients, which means the literature cannot help us about our really important question, which is, can we just wait for the meningioma to diminish? And the other question is, of course, what about the progesterone inhibitor mifepristone? Because our dream would be to find the tumors. In the literature, there is actually no univocal conclusion about the use of mifepristone in meningiomas. This review of the literature shows that there is really, in some studies, it's really positive. In others, it's really hard to conclude. GNR and others in 2015 published a randomized trial, which is quite big. It's got 80 patients in each arm, and they found no difference in failure-free survival and in overall survival. The thing is, that was quite a long time ago because they included patients in the 90s, and their eligibility criteria were really large. They were for any type of meningioma that could not be resected, and in many cases they had already record with radiotherapy. So that was a really, really vast group of meningioma. And in the article, there is no information about tumor location. So we have no contact them. Maybe they have this information somewhere, but in the paper there is nothing about it. And also they had no molecular and no histological criteria for including the meningiomas of the patients, which means some of them had progesterone receptors, others did not. Some of them were grade 1, others did not, were not. And we do not have this information in the patient in which mifepristone was a good treatment. For instance, we don't know in the placebo group, those who had tumor recurrence, if they were progesterone receptor positive or negative. So we lack a lot of information, but it's really useful that they've done this study, because we know you cannot just give mifepristone to any meningioma. We have to get more precise about the tumors. For instance, there's a case report. I mentioned it because it's someone from my team who published it, but it's very limited. It's just 3 case reports, but they had long-term efficacy up to 9 years in patients with cranial meningiomatosis, women with progesterone receptors. So when you target a bit more, maybe you get more efficacious with this treatment. The rationale behind all that, of course, is that it's now it's quite clear that specific locations are associated with specific molecular patterns. And for instance, TRAP7, AKT1 mutation or SMO mutations are found in some location of tumors in meningioma. And on the opposite, we know that exogenous hormone intake may induce specific molecular profiles in meningiomas. So it's in clinical practice, it's easier to get the tumor location to target the right patients than check the molecular patterns in this group, rather than just take all the meningiomas in general and look for some type of mutation or some type of receptor. So although it's quite I mean, it's a bit like old medicine because you have to go really to the clinical description of the patient. It's really linked to molecular characteristic of the tumors. And I really believe it can have some impact on therapeutic options we can give to some precise patients. So just to tell you a bit more, we've got an ongoing project and we plan to answer a bit some of these questions, but we try to be a bit ambitious, but not too much. So we are now starting a prospective collection of all the patients we see in the outpatients, so that means operated and patients with a wait and see decision. The aim of this is first to confirm our retrospective findings, because we are not really 100% sure whether those meningiomas are really hormone dependent or not, because we lack some precise information. We need more solid data. But the main thing we want to know is whether the tumor regresses when we stop it. And then the idea would be to confirm if there is or not a rationale for anti-progesterone treatment in some of those meningiomas. And maybe the idea could be as an adjuvant treatment in some cases. Well, this is just an idea for the moment, of course. And the fundamental idea is what happens in these regions that make these regions so prone to developing this type of meningioma, but that is just completely abstract at the moment. Thank you very much for your attention. That was an honor to share this work with you. And if anything comes to your mind, I will be happy to discuss it with you.
Thanks so much, Caroline. That was great.
I agree. A fantastic presentation, very thought-provoking. And I'm curious, I mean, so much of our neuro-oncological practice has shifted towards targeted and molecular mutational based treatment for brain metastasis for gliomas. And I think you touched upon what that could look like for meningioma patients. And so I commend you for that. I think that we should be exploring this more in the context of the underlying or underpinnings of molecular mutations within meningiomas and how one might target medical approaches as well as surgical approaches, and the potential risk for recurrence and the need for adjuvant treatments. So really very, very thought-provoking, and it begs the question of how do we get some of this information that we need to help to guide patients. But your studies helped to shed light on that in a way that I think was very, very meaningful. So
Thanks.
Yeah, I appreciate it. I have to say, while we were promoting this webinar, I got a lot of outreach from participants and viewers who are very interested in women's health, and they were particularly their interest was piqued by this, and they were very interested in watching it. And I do think it's important to kind of say that, at least it's my interpretation, and correct me if I'm wrong here, that the prevalence of these things, of spheno-orbital meningiomas, is extremely low. What you're looking at here is an association that you found amongst these tumors that will help us potentially target therapeutics for an extremely rare lesion. I don't think you're in any way suggesting that anyone who's been on birth control needs to be screened for a meningioma. Am I right, or do you think that that's a good idea?
No, you're perfectly right. That's why I tried to say that at the beginning of my presentation, because after the national guidelines were issued in France about cyproterone acetate, we saw dozens of patients coming to the clinic with like 1 millimeter meningioma or normal MRI, and their gynecologist had stopped their progesterone treatments because they were afraid of developing brain tumors. So we have to teach them that this is not true. So you're 100% right. Although there is that might be a risk factor, it is just it is extremely, extremely rare, and those meningiomas will be symptomatic, and there is no point screening them, especially when it's in the orbit, I think, because they will be symptomatic. And
yeah,
I think gynecological problems are by far more frequent and also very important. Yes, so you're right to say that.
Excellent point. I completely agree. Based on your study, we don't want a rash of people going to have initial visits with neurosurgeons and getting surveillance or getting scans.
But I do think it's important for gynecologists to interpret a headache. When next time someone presents with a headache, maybe take it a little more seriously. Not necessarily screening, but there is a potential association, or maybe screen better with questions about, are there visual symptoms associated with it. The other question I had for you, a little bit more in the granularity of the paper itself. 20% of these patients, or up to 20% about, weren't on exogenous progesterone. Did you see any difference in the tumors in those patients, whether it be the size or rate of progression, versus the ones that were taking exogenous progesterone?
So we saw that in the patients to answer about the tumors, there was no clear difference, but that's the aim of doing a prospective collection of data, is really to compare the bony part with the meningioma part, if there is more edema in the brain, if they were more symptomatic, and exactly what you're asking, going into the details of those patients, depending on their treatment, on their MRI, CT scan, etc. So, but as a general screening with all the data we had retrospectively, they were basically the same.
Yeah.
About the recurrence rate was 0 in patients who did not take exogenous hormonal intake. So I don't know how reliable this information is, but it is still interesting to notice that this was the case.
And I think was a thought-provoking aspect of your findings, which the recurrence rate, which one I thought was high, and two, the association with hormonal therapy. But one can't necessarily overanalyze that aspect of it. But I think it's hypothesis generating, certainly.
Exactly, especially because all the patients stopped their hormonal treatment after surgery. So it's really over-analyzing it to suppose that a previous hormonal treatment still has an effect 10 years afterwards. So it's just an observation, but I will not give any explanation about it.
Well, we're approaching the 30-minute mark. I really appreciate you guys' time. I know it's late there in France, and it's our pleasure to host you guys. Great work, phenomenal work. Jason, Nitesh, any final words?
I just want to say, you're probably hearing my audio coming in from Flora's account or something like that. I have multiple accounts running. Say hi to 25,000 people. You guys are broadcasting to live on the Lennox-Hill account. So thank you for coming. I mean, I think this is a really important paper. Especially, I was looking over my junior residents here because they're all asking the same question. How come these tumors always happen in the same places, these same types of patients? So I really think it speaks to the way we've molecularly been looking at these tumors, like we very much do for gliomas. So I think this is great, and I was really happy to come across this paper. Thank you for joining us.
I hope there'll be more studies to come, and hopefully published in Journal of Neuro-Oncology. The matter of women's health and neuro-oncology practice is very important to us. Thank you.
Thank you, and we'll be pleased to, if any of you is interested for collaborating about this, it's because most meningiomas are quite rare in each group, so please contact us. It will be an honor and a pleasure.
Great.
All right, everyone.
Thank you so much.
Goodbye, thank you very much.
Till next week. Bye-bye.